corn. Long tongue.
Banana slab.
Long
Kind of a
and
horseshoe shape, right?
horseshoe.
Like this, right? Okay, we'll go with corn. All right.
Half of corn.
It's all
Flat.
festive. Okay, and then how about the location of the spleen?
Right or left side.
Right on your left side.
Yeah,
Right on your left.
side.
Right on your left side. It kind of sits towards the outside of you and towards the back of you, right? All right, how about ductal interaction between biliary system and tank? Using anatomic terminology. Chris, had this on your homework.
Oh, this
Very
wasn't
good.
with the
All
chart.
right. Awesome! And who encircles the effluent water?
The sphincter.
Sphincter of Oddi. You got it. All right, next, vascular interaction between the spleen, tank, and the liver. What's coming from the spleen?
Splenic thing.
Where does it go in relation to the tank?
To the posterior
Posterior aspect of the tank,
body and tail.
tail, body, and then what does it become?
It
Confluence.
meets something.
Portal splenic confluence, and who joins it at the portal splenic confluence? And IMV, you got it. And then what happens when it becomes portal splenic confluence? Then it becomes what?
Main
Main
portal.
portal vein, and where does the main portal vein go?
Porta
What part of the liver? That's so weird. I wish I knew that. It, or enters the porta hepatis. Then if we want to get real crazy, what happens to the main portal vein after it enters the porta hepatis?
It splits.
Bifurcates into
Left and right.
left and right, and we have how many branches of each?
Two.
Two and
And
two.
what do we have on the right?
Posterior, anterior. Lateral, medial.
So, go to Walmart and do some studying.
Don't even know how to.
Years and years ago,
This
when I
one.
was a student, I lived in
The
Lakewood,
medial.
like in the middle. And that Walmart there, I used to go there because I was poor. I'm not a Walmart girl. But anyway, well, I say that my grocery store in Tenino is a hardware store and a grocery store, and that's everywhere. The toilet brush, and anyway, but it was like literally a week after I was there, there was like people shot up in an armored truck that were like getting money or whatever, and I was like, I am never going there. I gotta get out of there. This is a nightmare. Okay, so oh man, this is such a good image. It's almost like it might be on a test or something. I wish I knew. So what are we talking about? The very anterior.
Skin and fat.
Skin, superficial fat and fascia. And then who's this bad boy?
Left liver lobe.
Okay, and then let's start here.
Tail.
Tail of pain. Tail,
Body. Neck.
Head.
Head.
Uncinate.
And let's
Ans-
start with this guy.
Splenic vein.
Splenic
And who's
vein.
coming in here?
Superior mesenteric.
So
Mesenteric
who does this
vein.
become?
Confluence.
And he would go on to be.
Main portal vein.
And who's this bad boy?
SMA. Aorta.
IVC.
Who's sneaking between here?
Left renal vein.
And then who's all the way down here?
Vertebral column.
Nice one. Really like that. Okay, so are we sagittal transverse for the spleen? How do we know that? So the way I think about it, I don't know what kind of Tony mentioned to you guys about it. Draw a big F here. Sagittal is the top of the S.
The top.
The top. The sagittal is the top of the S. So if it's the opposite, it's the transverse.
Shea, could you explain us, please? As a rule, sagittal is transverse between them 90 degrees, and this.
Not for the spleen, baby. No. So that's the only organ that we don't have that.
Okay.
I know, it's really goofy. Let's find her.
So what did she say that was sagittal transverse? No, this here. The
It's
picture.
transverse.
Shoot up bubble gum.
Sagittal SS.
Because of the way the spleen sits in the body, and we're having to scan it intercostally, we end up with our sagittal, our notch is slightly posterior. And then when we do our transverse, we're gonna do 180 degrees. So our notch is actually be pointed towards our patient's belly buttons. So it's 180 degrees. So your measurements should be pretty much spot on. So if you're measuring your sagittal spleen at 10 centimeters, and you go to your transverse and you're getting 12, you need to go back to your sag, right? Whichever one's bigger is probably the more correct one. So kind of keep your eyes peeled on that. Now if I have pathology, then I'll try to obtain a true transverse, a true 90 degrees to that, so I can get an idea for how actually sized that pathology is. But when we're just imaging, it's 180 degrees. And you will go out in clinicals, they'll be like, that's not right, and then you'll watch them do it, and you're like, that's right. So keep that in mind. Yeah.
When you are calculating the volume and you use that coefficient is that
523?
yeah, is that because of the
That's volume of a rounded structure. So we use it for bladders, we use it for ovaries, we use it for anything that's a rounded structure. Because normally volume, you're thinking length, width, you know what I mean, like a box, but they diminish it because it's a rounded structure.
How would you get transverse?
You kind of shoot through the ribs. You might have some rib shadow. It's not going to look very pretty, but you're just trying to get the true transverse on that particular pathology. Okay, so how do we describe this? This is so weird. We're going to learn about this tomorrow in pathology.
Is it hematoma?
You're close. It's the opposite of a hematoma. It's the lack of blood flow. So we
Abscess?
call it splenic infarction.
Infarction.
More on that tomorrow. So how would we describe this? Is it well defined?
No.
Are you sure? Can I put calipers on it? Can I see where it starts and the spleen ends and all that?
Oh, the spleen?
Okay, so it's irregularly shaped, but it's still well defined. So we have well defined,
Regularly shaped.
hypoechoic. It doesn't have to breathe, that's only in cysts. It's solid. So what do we call that? Has mixed echogenicity, so it is
heterogeneous.
heterogeneous, located in the,
Anterior.
this is a tricky one.
Wait, this is a transverse
Actually,
spleen.
let's do this.
This
right
is
now. Give me a minute.
the
We're gonna do
lateral-
a thing. Shea's gonna make you do a thing.
lateral.
Okay. Talk about just, hang on just a minute. We're gonna do this. We're gonna talk coronal. Oh, and I have a few things too I want to talk to you guys about that aren't related to this, but when I went over your tests. We're gonna talk coronal. There was a lot of you that on your thing about what you don't understand said coronal. So this is coronal. Since we're in the coronal, we don't have anterior posterior anymore. We have medial lateral. Remember from your first chapter? Let's start with that. Let's talk. So those of you who have those of you that received these already, go ahead and put a notch where your notch would be on your transducer. I'm assuming there's enough. If not, I can always. It's really hard to make them.
Thanks, welcome. We have here 2 for me, 2 for you, more, and even 1 extra, just in case. We have. Thank you.
Sharon gets all the extras. Here you go, Sharon.
Oh,
Yeah, happy
Thank
birthday.
you. Is it your birthday?
I'm gonna build something with it.
There you go. Make a collage.
It's for my review project.
Your notch is gonna go the same place that it goes on your home screen, sector image, top left corner. What is it meant
Well, feisty there. Okay, everybody have one of these bad boys?
Uh-huh.
It's the kind of stick the notch.
Uh-huh.
It's got a notch.
Yes.
scanning the spleen. So what's the top of my image going to be? Left lateral? Left medial?
Superior, inferior.
Now, knowing that, we're flipped, right?
Yeah.
So does our lateral medial change?
No.
No. What did change? Superior and inferior. So where is this located?
Inferior.
Inferior, because we're flipped, right? And what about medial lateral?
Lateral.
Lateral.
Left lateral, inferior aspect of the spine. So let's talk about some coronal movement. Okay, so here we are. We're scanning coronally from the left. Boop, 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 boop. So we're going to end up with notch here. This is going to be left lateral, left medial, superior, inferior. So this is going to be for our sag spleen. Now, when we do our transverse, our notch gets flipped. It's the only time it really gets flipped, right? Otherwise, we're idiots and things are going haywire. The transverse spleen, you're still going to have that left lateral and that left medial, but now this is going to be our inferior, this is going to be our superior. So we do a 180-degree flip. It's the only time we flip our transducer, unless we are totally idiots and things happen. Sometimes with OB, I end up kind of creeping around. I'm like, oh, now I'm flipping it back.
Can
So
you
here we are.
describe the pathology again after?
Pardon me?
Can you describe in more words the pathology of?
When we're done? Yep, you got it. So how's that feeling for you? So in sagittal, by our notch is going to be superior, but when we do that flip, that 180-degree flip to scan this, our notch is going to be our inferior.
Mm-hmm.
So just need to know that. It's the only time we flip our transducer. Okay, so let's review real quick. So what do we decide? B's low. So we have well-defined, hypoechoic,
Heterogeneous.
heterogeneous or inhomogeneous.
Heter.
Pardon me?
Either.
Either.
Yeah.
Yep, either one works. Located in the
Inferior left lateral.
inferior
Jessica.
left lateral spleen. Yep, you got it. It's called what we call splenic infarct, and so for some reason, some either stenosis or a calcification or something's blocking the blood vessel going into that particular area of the spleen. They create these kind of wedge-shaped areas of necrosis. This will eventually calcify and die.
You said inferior left lateral splenic.
Spleen.
So it's just
More on
an
that tomorrow.
area of dead tissue.
It'll eventually, yeah, calcify and necrose. Get really gross.
Why it's hypoechoic?
Hypoechoic?
But it has to be some fluid to make it hypoechoic.
Not necessarily. Nope. And so we can think about it two ways. You'll get what's called splenic congestion. We'll talk about this tomorrow, where like the blood can't leave the spleen and the spleen will actually enlarge and get fairly hypoechoic. So that's where we have an additional blood flow. But in this case, we're having necrotic tissue.
And it would be dark too. But
Yep.
Hypo-
And as it ages, it will calcify.
Mhm.
So this will be a newer infarct. You can kind of see there are some areas of calcification beginning,
Uh-huh.
kind of right in here. But eventually, this will all get very hyperechoic and have areas of calcification.
There's a reason why, because
Orange transverse.
Yeah. Why? I don't understand. I need to read it because for me it's always some fluid, more
So here's our
fluid.
sag.
And she said it's just necrotic tissue, and I need to understand why necrotic tissue is hypoechoic.
So we went from here, so notch on this side, and then we had to flip 180, so our notch is on this side. So what's that? This side of the image is my inferior.
I don't understand why necrotic tissue is dark.
So inferior here, superior here. And think about it too, if you think about just the anatomy, our diaphragm's right here, so we know this is the top of our patient. We know our patient's head is that way. So this is the more inferior aspect. This is truly the most inferior aspect. Making sense?
So it's kind of like in the middle, we'll say it's like mid-inferior or?
Yeah, you can say mid-inferior, but I think of mid as being more like around hilum. And I think of superior as being upper. Because it refer to them as this, but you'll have an X-ray or a KUV that we follow up. So they'll say KUV X-ray. We're following up like, what's KUV? Kidneys, ureter, and bladder. Yeah.
They can also call the KUV X-ray a one-view abdomen.
Yep. One view abdomen, just depending on how far they go.
Yeah.
Because if they want bladder, it's included in the pelvis.
Gotcha.
So you got it.
Okay, cool.
Okay, so obviously we know what it does. Hopefully we know anatomy and physiology. We know the kidneys are important. And then we have two of them. Sometimes you can have more. Sometimes you can have less. We'll talk about that. And then we have ureters. Two of them. Sometimes you can have more. Sometimes you can have less. And then we have the bladder and the urethra. Usually only one bladder. I've never heard of a duplicated urethra, but I'm sure in the world of normal it's happened to someone. The multiverse has happened to someone. Okay, so kidneys. These are retroperitoneal structures, so they're going to be covered by a bunch of junk, and we're going to talk about what covers them here in a few minutes. Then we have these ureters, and one thing that I want you to kind of pay attention to, and we'll talk more about. So see how we have that sacroiliac crest, that's what we call the pelvic brim. So the ureters cross over the iliacs there, and so this could be a point where, like pregnant women, like the baby's compressing on it, and so it could create kind of an area of constriction, and so the urine won't be able to drain down. So that's its kind of one area of constriction. We'll talk more about that. And then we have, that's a prostate on it. And then we have our prostate, and then our bladder would live down here, and then our urethra, of course, is going to be that external organ. With that pelvic brim, we're going to talk more about that in a few minutes as well. The kidneys, ureters, and bladders. Technically, it should be a KUVU, because the urethra is involved, but you can take the word a lot. Okay, so here we go. So now, who's living posterior and anterior? For the aorta, that's the only vessel to run posterior to the IVC.
The right renal artery.
Right renal artery. And who, in the venous side, runs between the SMA and the aorta?
Left vein.
Renal vein. You got it. So we're kind of seeing that. We're not seeing that SMA very clearly, but we can be seeing SMA draping over this renal vein. Here we are on CT. So CT is very similar to us. They use density instead of, we use reflection, or sound reflecting. And we see kind of one small part, but they see everything at once. So we have spinal processes here. We've got our right kidney, so kind of the cortical portion of the right kidney. A little bit of that pelvis showing up. Now, why is this dark?
Blood.
Now, we think of dark as blood, but what do we think about with density? Is that more dense or less dense?
Less dense.
Less dense. So the renal pelvis is going to be less dense than the renal cortex. And so, like up in here, this is bowel gas. So we know gas is very, very low density, and so it's black. Bone is very dense, so it's going to be bright. And we'll talk imaging modalities, I think, in pathology coming up. But CTs are going to be measuring density. So we can't say something that's echogenic. Ultrasound is necessarily going to be echogenic on CT. Sometimes it works that way, such as with bone in this case. Other times, if we're looking at a bladder, our bladders are completely anechoic, whereas on CT, they're a little bit gray, because air is the only thing that has zero density. So they work in density, Hounsfield units. We'll get into that later. But here's the posterior aspect, anterior aspect. We've got some liver going on around here. So here's our right kidney, left kidney with, we'll talk about this in pathology, nephrolithiasis. That is a monster.
Yeah.
Or staff. So here we are on a X-ray. So we have stones in the ureter, you kind of see, a couple more down in here. And then we're really seeing a lot in this right kidney, and then just a handful in that left kidney. Why does that left kidney sit so high?
There's no liver.
There's no liver. You got it. You got it. Okay, so retroperitoneal structures. Again, that's going to be slightly inferior. So the left is much more covered by the rib cage than the right, and so it can be a little bit more difficult to image. So oftentimes for that left side, we have to end up a little bit more posterior and going through that kind of posterior lateral rib cage. We can get a little bit away with more anterior lateral on that right kidney. We see these little tiny adrenal glands sitting on top of the kidneys. With pediatric patients and adults, we don't see them unless there's some sort of pathology associated with them. Maybe they have a mass, and we can see this mass kind of between the liver and the kidney. We're like, what is going on? And so we might have to investigate when our patients breathe. Is this moving with the kidney, or is it moving with the liver? And we know it's neutral. So let's look at these guys. So the superior poles, this is a side view just like me right now. So the superior pole always sits a little bit more posterior than the inferior pole. So these aren't in here totally up and down. And when you guys start scanning, you're like, oh, it's totally up and down. You're like, what are you doing? It kind of goes with the rib cage. So when we scan these, we're gonna, let me get a key. It's an M&M's. Fair M&M over here. All right. Question is, do I eat it or not?
Only if it has nuts in it.
Okay. So these are going to sit slightly posterior in the superior and slightly anterior in the inferior. Additionally, they aren't going to be sideways in my body. This hilum is going to angle slightly medially and anterior. So instead of being straight medial, it's going to be medial and slightly anterior. Okay, so we'll look at the coronal view first. So that superior is going to sit slightly posterior, the inferior is going to be slightly anterior. And then instead of being straight medial, granted they're going to run into a patient every now and then that has it exactly perfect, but typically these are going to go slightly towards the anterior. So when we're going to scan these, we're going to do a lateral, a mid, and a medial. We're going to do a superior, mid, and inferior. So those are going to be kind of, we break these up and start scanning eventually. So that top is going to be rotated slightly towards the posterior, and that hilum is going to be rotated slightly towards the anterior. How you feel about that? All right. That's quite the gut on this patient, my goodness. Okay. Okay, so right kidney, you guys have seen him go by when we did the liver, so I'm go by. And then remember how I talked about that bowel gas being kind of covering all of this area? It loves to cover the inferior portion of that kidney, and it's going to be the flexure of the large intestine. So we talked about the hepatic flexure, maybe Tony did. So that large intestine is going to ascending come up, hepatic flexure is going to go over. And so we have like a little corner of large bowel here. So that bottom inferior portion likes to get covered in bowel gas. So we're just going to move more laterally and posteriorly to scan it. So we can clean those borders out, right? Corner, corner, corner. Okay. Now this guy, so this guy's going to be a little bit taller. He's going to be a little bit higher on the body. He's going to have kind of a spleen being his little kind of umbrella over here. Now he's also going to have that the splenic flexure of the large intestine. So we have that ascending, covering the kidney's inferior, transverse. And we're going to have that splenic flexure covering the inferior a little bit, and we're going to have the descending. But because of the rib cage, we normally don't have a bowel gas problem. We have a rib problem. So we end up having to go more laterally and posterior to scan this left kidney. So a little bit higher up, a little bit more posterior. This guy, a little bit lower, a little bit, you can get away with a little bit more lateral than posterior. How's that sound for you? Okay. And I will say as a general rule, when I scan, those right kidneys always look kind of long and lean, and the left kidneys always look really fluffy. And the more posterior I go on these patients, the fluffier those kidneys look. They measure the same. I have no idea what's involved in all of that, but they seem to get a little bit more fluffy and rounded as I go more posterior, in that left especially. And the left also measures usually about a centimeter larger. And so if I'm doing my kidney measurements and I get the right at 10 and I get the left at 9, I'm like, are you sure, left? Are you sure I got you all the way? So I'll have to go over there. So kind of keep an eye on the measurements too.
So they have to be the same?
They don't have to, but the left one should be slightly larger. So I'll double check myself. And sometimes I'm wrong and it's just the way that it is. Other times, like, yeah, I screwed up. Need to go a little bit more left. Okay, so here we are. Liver again, gallbladder, seeing a little bit of stomach, some material in the stomach, seeing a little bit of air. Here's intestines. So we have our left kidney here and our right kidney on this side. Now here's our little triangle of an adrenal gland. And we're kind of down at kidney med. Go ahead, Mark.
No, keep going, sorry.
We're going to move up just a little bit here in just a second to just see the adrenals. Okay, lad, we're not doing that. Okay, we're not doing that. We're not doing any of that. So we went up just a little bit more. So we're above the level of the actual kidneys themselves, and we see these little triangular superior hats that sit on top of the kidneys, and those are our adrenal glands. We see them on ultrasound really well on pediatrics, don't see them on adults. Okay, so let's go back to this bad boy. So we have IVC here, aorta here, so we're seeing, who is this guy?
Right renal.
Right renal artery,
Yep. Left renal.
left renal vein, we're not seeing the artery, but kidney cruising back here. So we have right kidney here, left kidney here. And not really seeing anybody else to the side. Okay, so here we're kind of showing that tail of that pancreas sitting anterior to that left kidney. We've also got that splenic, this is small intestine, but we've got that splenic flexion that's going to come over here as well. Cover that inferior portion. Right kidney, we've got a little bit of this duodenum covering him, and then he's going to have that ascending to transverse, that hepatic flexure of the large intestine covering him as well. So what are we doing? We have bowel gas.
Posterior.
Coronal.
Posterior. Yeah, Connor.
The CT images, could you show me the liver again? I just wanted to know if it was a healthy looking liver. It seemed brighter than the other image. That one looked,
There is something going on here.
yeah.
Yep.
And then
Something-
before
and
that,
look how lobular it is.
yeah. And then before that, the other image looked,
This guy looks okay to me.
what are those little bright speckles?
Vascularity.
Okay.
So depending on where the contrast is in your patient,
Uh-huh.
so see how bright like the aorta is?
Yeah. Oh,
Sometimes
yeah.
it won't look that bright. It just depends on where the contrast is.
Gotcha.
It's in either the PVs or the HVs. So we're
Vascular.
just seeing contrast within the vascular system. Yeah.
Thanks.
Why is it, I don't know, it looks like the left and rights are kind of switched or something.
Will be like our images, right? So when you are standing in transverse, you have anterior, posterior. Say we're at midline, right side, left side.
Head, father, patient, we see
So
on the
feet are
patient
this way,
feet.
and the head is
Yep.
in the toilet. Yep,
Yep.
you got it.
Oh, okay.
Yeah, so this is it.
Underneath.
Yeah.
Yeah,
We are looking from the
Your
feet,
up.
yeah.
That makes more sense. Oh, like that was.
Of course it is. It's all confusing. And if it wasn't, I would think you weren't being. Okay. All right. So there's an outer covering. This capsule. Garota's fascia. I have no idea who Garota is. I wanted that to be named after the fascia. But we don't often see or appreciate that capsule very often. There are times when our patients maybe have a traumatic incident, hit by car, boo kicked by their girlfriend after they cheated on her or something, but we may have to check for that capsule integrity. But in your normal everyday kidney without a hematoma, you kind of ignore that capsule. It does exist. If we get our kidneys nice and at 90 degrees to our beam, you may see a little echogenic line kind of creeping across because it's a specular reflector. So the cortex is going to be the outer region, that's a hypoechoic, remember the one that we make a comparison to the liver? And what are we making a comparison for? Which liver pathology?
Fatty liver.
Fatty liver, also known as
Hepatic steatosis. I can spell
hepatic
it.
steatosis.
Statosis.
And then we have the medulla, and that's the kind of inner region. These are kind of what we call pyramids. So when you guys have scanned kidneys, maybe there's like a little dark kind of triangular looking area within the cortex that you've seen go by. And those are the periods of pyramid. The base of the pyramid is towards the outer cortex. So these are going to all kind of angle in towards the pelvis itself. Then we have these calyces. So calyces, we think of the kidney, but the calyces are actually the collecting system for the urine. And I think of them like a deflated little rubber glove, like a little liquid lab gloves. And so we have the minor ones, which are kind of the fingers. We get into the major ones, and then they're going to dump into the pelvis itself. As we have some pathologies, that pelvis is going to fill with fluid, then the calyces start to swell, so you end up with what looks like a big glove in there filled with urine. And that's hydronephrosis, we'll talk about that. And then between the pyramids, those pyramids that are always pointing towards the pelvis, we're going to have what's called columns of routine. And sometimes these can mimic pathology because they have a very different echogenicity in the pyramids surrounding them. You're like, ooh, this is exciting. You're like, no, you're an idiot. It's just the way it works. And some patients who scan really well can mimic pathology just because we're not used to seeing things with that much detail. So sometimes that can be a little bit of a trouble as well. So, out in the real world, sinus and pelvis are used interchangeably, but they are kind of different. So one of them, the pelvis itself, is going to be that glove that connects to the ureter that's going to drain that urine out to the bladder. And around it is going to be the lymphatics, the nerves, the vascularity. But out in the real world, sinus and pelvis are used interchangeably. Okay, so let's look at this bad boy. So we got renal artery, renal vein coming in. So these are going to be our pyramids right here. Remember, they all point towards the pelvis. And then these columns of routine live between these. These are those little columns of routine. So our blood's being filtered here, and then eventually enters into these calyces. So these are the fingers of the glove. And then from the calyces, we have that major kind of pelvis portion, and then that's going to empty out into the ureter. Oh, I guess ureter. Ooh, okay. What more anatomically correct?
Shea,
Yeah.
the bands of cortical tissue, the bands of Burton routine,
Columns of routine.
columns of routine. What?
They're just structurally there.
Okay.
Yeah, so the big players are going to be the medulla, because they're the ones who are actually doing, like, they have the loops of Henry,
Yeah.
doing all the actual filtration, and those are just more like architecture holder-uppers, just, you know, so there's some distance between things.
Between the loops.
And there is a lot of vascularity to them, and they're shunting that vascularity to those pyramids.
Okay.
So when we look at, we'll talk vascular, but when we look at the transplant stuff and all that.
That's the blood to the
Kind of, yes, you got it. So there's actually going to be vasculature that runs between these, and it's delivering that blood to the pyramids to be
filter.
Okay, so hilum. So hilum is kind of where everything enters and exits the kidney. The three main players that we're going to see on ultrasound, hopefully you'll see the ureter, but the ureter's there, and then the vein and the artery. There's also lymphatics and nerves that go through here, but we don't appreciate those on ultrasound. Ooh, ah. Now, is this a right kidney or a left kidney? How do I know?
Right
How
kidney.
do I know it's a right kidney?
The liver.
How do you know it's a liver, not a large spleen?
Sits right.
Pardon me, portal vein, because we see some vascular structures. Yep. So here we have our cortex out in here. Pyramids are maybe a little bit prominent. It's kind of hard to see. I don't know if it's any better on this than it is. You kind of see some of these pyramids in here a little bit. Okay, so when we measure our kidneys, we're going to learn this in lab. We're going to do an overall length, 10 to 12 centimeters. As a general rule, I think 10 to 12 is pretty good. Don't memorize it. Just start working with these numbers. Hey, I measured so-and-so's kidney, I measured 9. I measured Tommy's, and I measured 12. So kind of get an idea for what these are. So it may not be that you're like memorizing, but like, hey, I ran into a 14 centimeter kidney. What is going on? Or I ran into a 7 centimeter kidney. What is going on? Did I screw up, or is this really a problem? Kind of just start working with these, like recognizing these numbers as you're doing it. Then we have the pelvis right in here. And we'll talk about the information here. So this is a pediatric kidney. Pediatric kidneys have what we call indistinction between the cortical medullary junction and the pelvis itself. So where the cortex is, where the pelvis is, it's really difficult to distinguish. There are some adult pathologies that have that, but in pediatrics we expect it. So they're going to be brighter kidneys, a little bit more difficult to see where the cortex is compared to the pelvis. And in this case, we've got our little tiny adrenal gland just hanging off the top right in here. As we age, we start to lose these. I don't even know what we're age for this, because I do babies and I do like adults, but I don't do a lot of in between. So pick an age, 5, 7, like this tall. I have no idea. So at some point, we stop seeing those adrenal glands as clinical. And here they are on CT. So we've gone from kind of kidney land, we've gone up superiorly a little bit, up superiorly a little bit, and now we're just seeing those little triangular tops of the adrenal glands on top of those kidneys. Can CT see them? Yes. Do we see them? No. They just blend in with all the fascia that's around there. So here we are in transverse. So I've got some vasculature coming in here. So here's the cortex, here's my pelvis, and vasculature coming in. So we're going to take this image as part of our protocol. And one thing we're going to do, if I see an image like this, I'm going to follow it up with color. How would I do that?
To know if it's blood vessel or not blood vessel, and which blood vessel.
So not so much even which blood vessel, but to know, is this a dilated ureter or is it vasculature? So I'm proving one way or the other. It might be hydroureter, what we call fluid-filled ureter, hydroureter, or it might just be vasculature. But if I just submit this image, my radiologist is like, what was that? I'm like, trust me. They're like, okay, you go to the court of law, and then you actually, hydroureter, and then kidney exploded and she's filled full of pee and she died. So, okay, oops, could have saved that by doing one color reduction. So making sure we're following up this with color and real work. Okay, here's the left kidney. Left kidneys, you're not going to be able to get as much like window. Sometimes you can use the spleen as a window, other times not. It's much better to use the spleen on your transverse kidneys for a window, whereas we can use that liver much, much more so on that right side. But here we have our cortex out here, and then we've got our more hyperechoic echogenic pulse. Okay, are we right or left? How do we know?
Right.
Right, liver, oil veins.
Liver? How do you know that's the liver, not a spleen?
Oil veins.
You can see how kind of long and lean those right ones look. Compared to the left. They look a bit fuzzier and rougher. We usually don't have as much distinction because we don't have that liver window. With this, we can really see that dorsal capsule. Remember I talked about it, this 9 degrees to our being more appreciated. But if you go to this bad boy, it's okay. So that's going to be a little bit more difficult to identify pathology. Okay, so here we have a renal stone. So here, our urinary is coming out somewhere in here. We've got this echogenic shadowing foci, right? And this, we'll talk about where this area is. And now I've got some fluid. So that, remember that glove, remember the pelvis to the calyces? That glove is starting to fill in the palm part. And if this continues, it will start to fill those major and minor calyces, and those fingers will kind of extend out to the
Can we say it left or right? Sorry.
best guess would be right, only because we're totally covered.
Mm-hmm.
That's just a guess. Without scanning, I figured that out. Without scanning, is it which iliac is this? I don't know. Okay, so renal arteries. So we know where it comes from. It comes from the aorta. One on each side, right? And so remember, our arteries are always going to be posterior to our veins. Our bodies like to protect arteries. If I cut an artery, it's much worse than cutting a vein. So typically deep to our skeletal structures, deep to our bones, deep to everything, you're going to find arteries are always a little bit deeper. Our body's trying to protect the core. So our renal arteries are going to be way retroperitoneal, way protected by that rib cage, and the veins are going to be more anterior to that. That guy's going to stick into that hilum. He's going to branch out, and then we have some more that we branch out with. So we're going to have the main trunk of the tree, a couple big branches, what we call the segmentals. Those are going to further branch to the interlobars, and those go from the pelvis to the cortex itself. And then we have these little tiny leaves at the very, very top called arcuates. Third quarter, we're going to do a practice transplant kidney exam. We're actually going to do resistive index Dopplers on all of these things. And it's a protocol that I do in my work. It takes forever, but I really like doing it, so you guys will learn how to do it. So you've at least had it under your belt once. So we have the major trunk of the tree, so the renal artery, branching into those segmentals, further branching out into those interlobars, so between the pelvis and the cortex or those interlobars. And we have all the little leaves on the tree, which are called arcuates. They're out way, way out in the cortex. Here we go. So our renal arteries coming in, bifurcating. So here's our segmentals right in here. We get to be in these interlobars, going from the pelvis out into the cortex. And then these little teeny tiny guys are all the arcuates all around here. Okay, renal veins. They're okay. So then we're kind of coming back. So we're going from the arcuate veins down to the interlobar veins, down to the segmental veins, and to the renal vein. And these are going to drain on the lateral IVCs. So where's that right renal vein here?
Behind.
Is it anterior or posterior?
Posterior.
Anterior to who? Renal artery, right? Where does that left guy go? He has a weird life.
Between aorta and SMA.
Yep, so posterior to the SMA, anterior to the aorta. You got it. And he's a little bit longer of a reach, right? This goes all the way over. He's on the right side of the body, have him go all the way over the body. Okay, okay. So this is what we call the tree of life. And when we do a renal ultrasound that's specific to the kidneys, we're going to get this image. If I'm just imaging my kidneys with my abdomen exam, I'm not going to worry about this image. But when we actually are evaluating the kidneys themselves, we're going to get this. Now, blue is going away from my transducer, red's going towards. So are blue my veins or my arteries? case, I know I told you guys to ignore red and blue, but in this case, it works.
Yeah.
So the reds are actually coming in and perfusing. So we have renal artery coming in, bifurcating into those segmentals, further bifurcating into those interlobars, going from the pelvis into the cortex. And then we have these little teeny tiny guys, the arteries out the top. When we do this image out of the real world, we also want to make sure that we're showing perfusion to the superior, the mid, and the inferior. Because you can have obstruction of one of them, but not the other two, or 2 out of 3, or whatever. So what we want to make sure we're doing is showing all of this. So in this case, I didn't see much of the superior, I'd take an additional image. Or I might just break this up into superior to mid, and then mid to inferior. It's going to give me 2 images, yeah.
And this is part of a retroperitoneal limited.
Pardon me?
This is part of our retroperitoneal limited.
So out of the real world, we call them renals, but when they're orders as a retroperitoneal. They never call them renal exam, we call them renal exams. And these are your favorite stupid exam that you're going to do. Inpatients, this is our #1 exam on inpatients because they get them in the hospital, they put them on meds, they put them on fluids, their kidneys go a little haywire, so they have abnormal kidney values, and they're like, you better look at them. Like, well, they're peeing, they don't have any complaints. What are we doing here? So we're trying to evaluate some problem they have developed in the last 5 hours that they were there. I'm like, I don't think that's happening. But these are very common inpatient exams. Here we have what's called power Doppler. We haven't touched this button yet, so we're used to so far directional Doppler. It's going towards the transducer or away. Power Doppler we'll learn about in physics, and it just picks up any flow that we can see. So whether it's low velocity or high velocity, we typically use it for low velocities. It's really good for low velocity. So if I have a testicle that I'm not sure if it's twisted on its blood supply, then I'm going to use this power Doppler and be like, what's going on? It picks up lower velocity flows in this power Doppler. Here's our renal artery coming in. We're branching into those segmentals, further branching into those interlobars, going from the pelvis to the cortex. And then we're not really seeing the arteries out here, but there will be little teeny tiny polka dots all around the most lateral aspect of the vertebra of that kidney.
Can you say again what is the point of this?
Pardon me?
Can you say again what is the point of this power Doppler?
It shows very low velocity Doppler shifts. It doesn't give us direction, but it can say like, is anybody have flow? Like, is anybody flowing? So if I have a torsed testicle and I put my color Doppler on and I can't pick up any flow and I've dropped out my settings, I've increased my frequency and did all the stuff that you don't know how to do yet because it's physics and don't worry about it, then I would throw power on.
Basically just a little more powerful than color Doppler.
They call it power Doppler. It's not really more powerful. It's more sensitive, like my boyfriend is. So here we are in transverse. So we've got perfusions. We've got renal artery coming in through that. So here's our cortex here, seeing a little bit of pelvis. So we're going to shape like a big C. No kidney over here. So we've got renal veins exiting. We've got renal arteries entering. So we're kind of showing perfusion right at that pelvis in transverse. We saw this one go by already, just kind of showing it to you again as a visual. So aorta, there's that artery, there's the IVC, vein, and vein. Okay, oh, what happened here? Okay, so renal anomalies. So we can have renal agenesis. Where did it go? I don't know, they weren't born with it. That's so weird. I don't know what happened. That's very strange. So that happens. Nowadays, that's not like a real person. Oh, well, no, folks, we're young. So nowadays, ultrasound is much more common during obstetrics than it was like in my day. Like I'm a twin and my mom had like an X-ray of us. And I'm like, okay, cool, that's detrimental to me as a first trimester fetus. Okay, cool. But nowadays they're catching a lot more of these like renal agenesis and these renal abnormalities on obstetric ultrasound. So we're not actually diagnosing them for the first time anymore, unless you have an older patient. And so I would say since patients born in, say, mid-80s and later, we're not going to be catching anything that we didn't really catch on an obstetric ultrasound, especially these newer patients if they're going to be pediatric patients. We've not been following up when they were a fetus, and now they're a teen or a adult. So a lot of times these are kind of known conditions, but just keep in mind, you're going to get the 60-year-old who's been healthy their whole life, and you're like, where's your kidney? Oh, it's in the wrong spot. Well, we don't have it. So keep that in mind. It's going to be more older patients. So if we have bilateral renal agenesis, incompatible with life, do not pass go. They make it out of the womb, and that's about as far as they make it. They may not even make it out of the womb. They may not survive to be delivered. So renal angiogenesis, we have to have at least one. So unilateral, we can have, that's comparable with life, we can do that. So many patients who maybe had like they donated a kidney or one of their kidneys failed or they had renal cell carcinoma, they removed the kidney. In that case, the other kidney gets a little bit larger, so up to like 14, 15 centimeters. Abnormal fusions, so there's a couple ways this can happen. So there's what's called a horseshoe kidney. So cool, it's a horse in it. But basically, the kidneys, so during 16th week of development, the kidneys live in the pelvis, and they come up into their, I guess it is, their renal fossas. And sometimes they're attached when they do that. So I might have one that's attached, and it's a big kind of horseshoe shape, and it just goes straight up my patient's abdomen. So I see it in the anterior portion of their abdomen. So you're like, where's your kidneys? And you go here, like, that's a giant weird kidney. You can have what's called a cake kidney, where it's fused kidneys, but instead of being two discrete kidneys, it just looks like one giant weird kidney, misshapen kidney.
But it was good, yeah?
What's it? They work fine. Yep, yeah, they work. They're just weirdos. Yeah.
And the horseshoe kidney is still retroperitoneal?
Yes.
Okay.
Yeah.
But isn't it more?
For the most part. I mean, then if that's not the case, then they're ectopic horseshoe kidney.
Okay.
So it can have like two labels at that point. Yeah.
Aren't they like not more dangerous for a person, but easier to like?
I would think
touch
trauma
and retrieve?
wise, but I
Yeah.
haven't really. They're so rare that it's not been like, I got hit by a car and I have a horseshoe kidney. You're gonna be like, okay, well, you never want to, you know. So
Yeah.
I haven't experienced that, but I'm sure somewhere in the realm of the multiverse it has happened somewhere. And then you can have what's called cross-fused, cross-renal ectopia. So these kidneys were in the pelvis. They decided they wanted to be best friends forever. And so they stick together, and then they either go up to the left together, or they go up to the right together. So you have two of them together in one. Dromedary hump. So this is very common, and don't be ashamed. Be like, oh, this is amazing. So this is going to be continuous with the cortex. It just has a big lump on it. These are more common on the left versus the right. And then we kind of talked about this with Connor just a second ago. So sometimes these don't, they start in the pelvis, and sometimes they don't make it all the way up, or one of them makes it up, or neither one of them makes it up. And so they can actually be down in the pelvis, or halfway to where they're supposed to go. So they make it all the way up to the renal fossa. And then that junctional parenchymal defect. So this is, it looks like when you're scanning your kidney, it just looks like a little echogenic kind of triangular shaped star in the cortex. That's the only thing that we really notice about it. But basically there was a junctional defect during development. And so it just kind of created a little scar tissue. And it looks really common to normal scar tissue. Okay. So, where are you? Okay, so cross-renal ectopia. So I have one kidney here, and his best friend is right here. So they didn't separate. These look very similar to what we call duplicated collecting systems, where you have a kidney that's one kidney, but it has two ureters, two everything. The difference is going to be this band of tissue will extend all the way down. With those, with the collecting systems, they may have a little bit more tissue, but there's still going to be a separation. You see pelvis go from one side to the other. Cross-fused ectopia, there's going to have a closed cortex, so it's like two kidneys that are stuck.
Is this a transverse image?
I don't think so. I think it's a sad.
This is sad.
Looks sad to me. So I think if it was transverse, it would be much smaller pelvis. You know what I mean? Like, you know how you see like just a much smaller
That
pelvis.
makes sense. Okay.
Oh, dromedary hump. Woo! How exciting. Look at this pathology. Let's measure it and write scholars about it because it's so exciting. It's like, just a dromedary hump. So right, greater than left. And it's just a common variant within the cortex as development occurs. Again, more commonly on the left than the right. Okay, here's our horseshoe kidney on CT. So we've got liver here. Normally we'd see, right, like a focal kidney here and a focal kidney here. And instead, we're seeing this horseshoe kidney crossing the aorta. Pretty wild. Pretty wild. Okay, so any questions on the kidney part of this? Alright, so who's gassing out our kidneys with the large intestine on the right side?
Hepatic flexure.
Hepatic flexure and kind of the duodenum a little bit too. How about who's covering the inferior portion of the kidney on this side? Splenic flexion, got it. Alright, ureters. So, we don't want to see these. If we see them, something is wrong. So what we have is kidneys are draining this. This is kind of similar to our biliary dilatation. kidneys are draining this urine, it goes into the ureters, goes down to the bladder, and gets pumped into the bladder. If I'm seeing dilation in the kidneys or in a ureter, I'm going to check downstream. What's blocking this? So the urine is being made in the kidney, it's going down the ureter, it starts to backfill the ureter, starts to backfill into the kidney. So what is even happening right now? So we want to look for obstruction. We'll get into that with pathology stuff. The way we can disprove any kind of obstruction is I'm going to go to the bladder, put my color Doppler on, and I'm actually watch these little jets squirt out urine. The right side, the left side, and I do it together. And that's how I know, like, okay, from kidneys all the way down to bladder is a clear pathway. That's why I prove that pathway. If I can't find a jet, sometimes you don't have any evidence of obstruction. There's no hydronephrosis, there's no fluid in the kidney. There's no fluid in the ureter. But I don't find a jet. Sometimes our patients are just dehydrated, it doesn't happen. And we'll talk more about this with pathology, but we're going to look at those jets. So it's going to exit at the hilum and goes inferiorly along the posterior kind of abdominal wall. And that's that common ilia of the sacroiliac joint. So that's where that pelvic rim is. Pregnant women, very commonly, as those pregnancies continue, that will start to compress on that pelvic rim. And the ureter's like, oh, something's squishing me. I'm just going to start filling with fluid and create problems. And if you roll them on their side and that pressure's relieved, that kidney will empty. The kidney and the ureter will empty. Other times, there's actually a stone in there. Or maybe there's a huge ovarian mass that's compressing on that. So we want to determine, is it intrinsically blocked, like there's something within the pathway, or is it extrinsically blocked, something outside the pathway is compressing on it. Okay, so the trigone of the bladder. So in the posterior inferior aspect, it's this little tiny kind of muscular area on the bladder, and the ureters plug into the posterior aspect of it, and the urethra exits out the anterior aspect of it. So it's called the trigone. And when we start looking for those jets, we're going to be looking where those ureters plug into the trigone, because that's going to be on that inferior posterior aspect of the bladder. There's also two other areas that we talk about having constriction. So we talked about that pelvic rim, that sacroiliac joint with pregnant women. But then you can also get stones stuck places, or you can get mass. And one of them is called the UPJ, ureteropelvic junction. So the ureter with the pelvis of the kidney. So ureteropelvic junction, UPJ. And the other one's the UVJ. So ureterovesicle. Vesicle is bladder. You guys ever seen like that incontinent or prostate? It's like vesico to make your lives better. Or vesico is the name of the medication. But anything with vesico is going to be bladder. And so ureter-vesico junction, so the ureterovesical junction is UVJ. So that's at the ureter where it meets the bladder at that trigone. Wow. So in this case, we've got our ureters coming in. They should have a little dotted line, and then you can kind of see where they're actually opening in that posterior inferior aspect, and then the urethra makes up that kind of third leg of the stool. Yeah.
Is urethra inferior, anterior?
More anterior.
More anterior.
And more inferior. So if we think about,
So
this is sitting in the body, something like this. So where the ureters enter is going to be posterior inferior.
Yeah.
So this is going to be slightly tipped more inferior and more anterior. And if you think about where your urethral opening is, especially on females, it's more anterior, right, than the retroperitoneal ureters. Let's say the word ureter 19. Yeah. And then for females, same thing, but the urethra is going to be a little bit different. We'll talk about prostates later, but male urethras are a little bit longer. Number one, because they have a penis. Well, it's longer. And then number two, they have that prostate. We don't have that. We used to have kind of a blank area that Okay, so here we are, hydroureter. These are really terrible images. So this is our kidney, and you can see here's our ureter right here. And so we've proved that it's a ureter by putting color on it. And so proximal is the portion at the kidney. Distal is going to be further down. So I want to keep cruising further down to see if this has an area of obstruction. Is there a stone? Is there something pressing on it? And in this case, we have a stone. So here's our right ureter. So you can imagine that kidney was up here. We saw that ureter was dilated. So we followed it down, and then we see this little echogenic foci. And then we don't see it afterwards. So we know that this is our area of obstruction. We expect to see a jet in this patient. Right here, a little jet.
it's obstructed.
It's obstructed, right? You got it. Okay, so here we're seeing, and this isn't quite where they meet up with the trigone, but this is, you can see we have a little bit of hydroureter bilaterally. So if I have bilateral hydroureter, so I've got a blockage on my right side and a blockage on my left side, the chances of those both being blocked by stones is pretty minimal. I'm gonna be looking in the bladder or the urethra if I have both sides blocked. Let's go even further downstream. If it's one side, I'm gonna kind of follow it down, maybe to that UVJ, see what's going on. But if I have both sides, I'm looking at a prostate problem, I'm looking at transitional cell carcinoma, I'm looking at urethral stone, something that's like an outlet obstruction, that pee isn't even able to leave the bladder, so it's backing up both sides by lateral.
And did you say something about pregnancy causing compression?
Yeah, so that sacroiliac rim, the ureters run right along it, so these later gestations,
Yeah.
especially if they're laying on their back,
Yeah.
the baby's compressing it, so it's like, wow. So, same as like a giant mass, right, on pregnancy, you know, but, so it'd be the same as like, you know, and if you roll them on their sides and relieve that pressure, that will
Side is
empty.
very nice.
Yeah, it will empty. Okay, so here's what our jets look like. So in this case, for the inferior, posterior portion of the bladder, and when we do this in lab, you'll kind of see there's like a little bit of a bump here. We'll talk about that later in the scan. But the right is always going to shoot towards the left, and the left is going to shoot towards the right. It's going to shoot in the other direction. The little volcanoes. Okay, so urinary bladder. Any questions on ureters? Very exciting stuff. So should we see them?
No.
Oh, looks like I have to do more. I scan of the scan more. Okay, so it's a reservoir for urine, and we know that it's located, and we'll talk about this later, the true and false pelvis, and it's actually going to be in the we'll on that one later. But anyway, so anterior to the urinary bladder is our pubic symphysis, and when I'm scanning a bladder, and I have my patient use the restroom, and they void all the way, and I can't see the bladder, I'm going to prove my location with this pubic symphysis. And basically, you're going to see this echogenic bone with a lot of shadowing, and that's how we prove our bladder location. We'll talk about that in lab when we scan. And then posterior to the uterus is going to be either the prostate or rectum. And let's go back to this one. This is actually, we're seeing rectum right in here. So that's posterior to the bladder, is going to be that rectum. Okay, so we talked about the trigone already. Oh, and then the wall thickness. So if my patient has a cystitis or a bladder infection, that wall's going to get thick, remember like our gallbladder did, and might get some wall edema or some hyperemia in there. But if my patient doesn't have a very full bladder, like we have them do prep like 32 ounces 1 hour beforehand, and they're like, oh yeah, 6 in, oh I did it, oh no, you're really good. So they don't have a very big bladder, they may have a thickened wall. So it's relative to the size of distension. So if I have a thick wall on a very large bladder, I know I've got a problem. If I have a thick wall on a small bladder, possibly have a problem, but chances are it's just because it's not distant. Okay, so again, if this bladder is empty, if my patient voids all the way and there's 0 left, I'm not going to be able to see any features of that bladder. I'm not going to be able to see the wall. It just blends in with the bowel. If it's full, then we see this big anechoic structure, right, that we kind of saw go by a few minutes ago. We want to show those jets, and when we start doing pelvis next quarter, if I'm looking at prostates, the bladder enhances, right? It doesn't attenuate. There's no beam reflecting back, and so I get a lot of enhancement. So I can use that enhancement, we'll talk about this next quarter, to actually look next to the area outside of the uterus, to look for my ovaries, to use it to look at the different features of my or your, don't remember, uterus, or prostate, not my prostate. But anyway, so but you can actually use it as kind of a window to scan through, because we can use that enhancement to kind of clear out, kind of shine the light on a little bit different pelvic structures. So we'll get into that a little bit next quarter when we start doing pelvics. It's a very important skill to know. So transverse, our bladders have a tendency to look like big square boxes on transverse. We've got this nice square box. So anterior, posterior, because we're midline, now we actually do have a right and a left. We haven't really had that before. And here we are in sagittal. So we're not really seeing the inferior portion or the superior portion. We're kind of showing off this uterus. So vaginal canal, cervix, you'll memorize this later. Here's our body kind of fundus. And here's our anechoic bladder. So you can see the enhancement is helping us see this pelvic, the pelvic structure. Here we are in transverse with prostate. So here's our kind of big box of our bladder. We've got a little bit of connective tissue, and then here's our hypoechoic prostate. And we'll get into prostates with male pelvis later. And St. Clair's has a prostate probe, thank God I don't know. Here we are in sagittal transverse. Again, we'll get into these a little bit later. The sagittal view of the bladder, a little bit more kind of a teardrop or a lung shape. Here's our prostate right here. Ignore the calipers, they measure this wrong. These are actually the seminal vesicles coming off of the prostate. They're like little wings that hang on the prostate.
And do we see those normally? The seminal vesicles with all the stuff?
Pardon me?
Do we normally see those seminal vesicles? Is that
No,
right?
it really depends on your patient.
Okay.
I would say no. I think we
Okay.
saw yours.
I don't remember.
I think anybody who's been scanned at here we've seen that some of those bigger body patients, you're just not gonna see it
Oh,
very
I
well.
see.
You're lucky to see the prostate at that point.
Gotcha.
So,
Okay.
and then here we are in transverse again, seeing that prostate posterior on the inferior aspect of the urinary bladder. Okay, urethra. So we've gone from kidneys to ureters to bladder, and where are potential areas of constriction from the kidneys down?
Pelvic rim.
First at the kidney and the ureter.
Yeah.
The pelvis of the kidney to the
UPJ.
ureter.
UPJ.
UPJ, and then we have, as we get down into the body, no, before we hit the bladder,
Pelvic brim.
we're not there yet, pelvic brim, the sacroiliac junction,
Sacrum.
and then we get all the way down to the bladder, UVJ, which is urethro junction. Okay, good, all right, sounds good. Okay, so then, we're in the bladder, we're urine, we're hanging out in the bladder, and now we gotta go. Shea's gotta go to the bathroom, she's got a road trip coming up, it's really terrible. Do not ever go on road trips. I'm like every 2 hours. Oh, I'll tell you my pants peeing stories and this is one thing. So, I'm 43 now, this is probably when I was like 35. So we have a big farm over in East Washington, that we run cattle and crops on. And it's over towards George, you guys know where George is, Moses Lake, in the area? Okay, so it's like a few hours away. So Dad's driving, and of course Dad's like, this is like 1975, so he's like a sick pack in the truck. But anyway, so, I'm like, Dad, I really have to go to the bathroom. He's like, oh, we're almost there. We stop at, in Ellensburg, this like burger place, Ross's Utona, I don't know if you've ever heard of it. Amazing burger, by the way, and shakes and stuff, but anyway. He's like, we're almost there, we're almost there. I'm like, okay, yeah, we're there. I'm like, dying, like crying yellow tears. I'm like, no, like, do the wiggle thing. I'm like, Dad, I really have to, can you just pull over? Can you just, more like, I can you just pull over? I don't even care, I'll just pee on the side of the road. I don't care. He's like, oh, we're just about there, we're just about there. It's not like statue. Like you go from like wiggly to being like, I can't move, right? And then that's the thing. So we get there, they go to get out of the truck. I think just the movement of getting out of the truck. I pee my pants. And I'm like, Dad, I just peed my pants. Well, what did you have for? What did you tell me I had to pull over? Yeah, so Dad. Okay, so the urethra is a membranous tube, and it goes from the urinary bladder out to our external kind of wherever. If we're a male, it's going to go through the penis. For a female, it exits kind of on the anterior aspect of the vaginal opening. So just depending on where we're at. So women again, 3.5 centimeters. Men, depending, 20 centimeters. And we have two sphincters, an internal and an external. So let's talk about this. So in this case, this is not the so we're seeing this is uterus, you guys don't know this yet. This is a not very distended bladder. Urethra is running down here, we see a little string. And here it is in transverse, so our little box bladder, not very full. And then here's our urethra would be exiting, and we've got this little stone.
We are watching from our tummy, still from our low tummy.
Yep, kind of right above the pubic symphysis. And I would say ureteral stones are more rare to have just happen. Oftentimes what will happen, or urethral stones, oftentimes what will happen is they'll have a patient who has kidney stones, and they'll break it up with what they call lithotripsy, kind of shake the stone up and break it up, and then they're supposed to just urinate it out, and then one piece will get stuck. So then they'll come to us like, it hurt up here, ow, it hurts down here, and we're like, And kidney stone and urethral stone patients are, aside from testicular torsion, they're the most painful patients I have. Absolutely, hands down. Has anybody ever had a kidney stone? No. rock. You have to pee on a rock. So very painful.
What did you just say about the urotrip?
Lithotripsy.
Yeah,
So-
lithotripsy.
Oftentimes these urethral stones are fairly rare to have just happen.
Gotcha. Yeah.
What will happen is they'll have like a kidney stone and they'll do one of those lithotripsies where they break it up. They use not our kind of ultrasound, but they use basically ultrasound to break it up into
Cool.
smaller components,
Yeah.
and then they're supposed to pee them out.
Ah.
And so, I know.
That sucks.
And so oftentimes you'll have a bigger chunk and it will get stuck in the urethra. But it's pretty rare that I just see a urethral stone without having a history of kidney stones or a history of something. So.
You called it a urotripsy?
Lithotripsy. Lithography. So litho stone
Stone.
breaking
Litho.
up. So stone breaking up.
Lithotripsy. Like tripsy.
Okay, so here we're seeing one, and we're actually seeing this. So the urethra runs through that prostate, and so here we have our prostate, and we've got a big stone obstructing our urethra within the prostate. Okay, so here's our urinary bladder on CT. CT. X-ray. So we talked about kind of those adrenal glands that were way up here. We went down to kidney gland. We didn't really see any ureters, but we're going all the way down to that pelvis, and now we're seeing the urinary bladder. So here are our iliac. So vertebral body of the sacrum. Here's rectum right in here, and then we've got this urinary bladder. Why isn't it black? Like we are?
That's debris.
Density. It has
Because
fluid.
it's density. You got it. So the things that are dense, holding it apart there, hard to imagine it's CT tech. But yeah, so the things that are going to be black are going to be things that are very low density. You'll be surprised when you go look at some of these CTs.
Probably nervous.
I know, but I'm not saying I blame them. I would probably be the same way, but why do- Okay, so when we do these exams, kind of like Connor brought up earlier, these get orders what we call a retroperitoneal exam. We call them renals because we know we're looking at the kidneys and the bladder. But they're called retroperitoneal because they want you to look at the aorta, ureters, bladder, urethra if you can see it, and kidneys. So they order them as a retroperitoneal, but we just call them renals. Lymph. So far we've measured things kind of in one plane, or maybe two for the aorta, but we're gonna have three total planes. So we're gonna have an overall superior to inferior, an anterior to posterior, and a front width. And we'll talk more about this in lab as well. Sometimes too, depending on your site, they may have you do what's called a cortical thickness. So as our patients have hypertension or kidney failure, the cortex of the kidney gets very thin. So here's our kidney in stand, and here it is in transverse. So we're going to do a superior to inferior, and then I always do my two measurements here. We'll talk about why in lab, and then we'll do a width and an AP. We get three measurements out this bad boy. If I suspect that this is thin or my site requires it, I'll also do a cortical measurement. Just measuring that cortex. We'll talk about how and why when we get to
Oh,
Okay.
okay.
So we talked about that transverse, how that kidney's going to open towards that medial aspect, kind of slightly towards that anterior. And some of our pathologies, we're going to have a change in echogenicity between the pelvis and the cortex. So remember that corticomedullary indistinction, where it's harder to tell where the cortex is or where the actual pelvis is? That applies to some of our pathologies. So when we get started talking about pathology stuff,